Hello, everyone, and welcome back to more human physiology. So in this video, we are now going to start discussing blood pressure measurements and the different factors that affect someone's blood pressure. So in the previous video, we talked about blood flow and how one of the determinants of blood flow is the pressure difference between 2 points in the circulation. So this video is going to allow us to learn a little bit more about how pressure can change at different points in the circulation and how those pressures can actually be measured. So before we start specifically talking about blood pressure, let's review a little bit of what we've discussed about blood flow. So this handy table from a different textbook, not the one that you have, but a different textbook, does a pretty nice job of summarizing some of what we've already talked about. So number one, blood will flow if there is a difference in pressure between 2 points. So obviously if the two pressures are exactly the same, then delta P will be 0 and the blood flow will be 0. So in order to even begin talking about blood flowing from place to place in the circulation, you've got to have pressure differences. When a pressure difference does exist, blood will always flow from high pressure to low pressure. We've already covered that pretty extensively. The opposition to blood flow comes in the form of vascular resistance. So that's, as we said, that is a separate issue from delta P. Delta P could be very, very high, but blood flow could be very poor if the resistance to flow is also very high. So there are three factors that affect vascular resistance. The radius of the blood vessels, that is the major determinant of vascular resistance, as we saw with Poisson's equation. The length of the blood vessels, and the viscosity of blood, which should not change too terribly much. So really it's just going to be the radius and the length of the blood vessels. The radius being the major issue. The last 3 points you can see there are not terribly important for us, but you can see some information about the units of blood flow and blood velocity. And the relationship between 6 and 7 is something that we're actually going to see in the next video in the sequence, so we won't worry about that just yet. Okay, blood pressure. So when someone discusses their blood pressure, whether they have normal blood pressure or they have high blood pressure and they're on medication for it, the kind of casual reference to blood pressure actually refers specifically to arterial pressure. We'll see later on that venous pressure is a totally separate issue. So when someone's talking about their own blood pressure, they are talking specifically about their arterial pressure. So I'm sure you're aware that there are two different arterial pressures. There's a systolic pressure, which is a high number, and diastolic pressure, which is a lower number. The reason for these two different numbers is going to relate back to the function of the heart as it goes through each cardiac cycle. So because the left ventricle is going to be toggling back and forth between its own systole, which is contraction, which drives up the pressure inside the ventricle, and then a diastole period in which it is relaxing and the pressure is relatively low, because the left ventricle goes through this high pressure, low pressure, high pressure, low pressure toggling back and forth, that is also going to cause the pressure in the arteries to toggle back and forth between a higher systolic pressure and a lower diastolic pressure. The difference in pressure between the systolic and the diastolic pressure, which we will find out on the next slide, is called the pulse pressure. That is literally due to the delivery of the stroke volume. The arteries have to expand to accommodate that extra volume of blood, and as such, they experience a higher pressure. As I said, blood pressure in the kind of casual colloquial sense refers specifically to arterial pressure. Venous pressure is usually not referenced very often because it is understood venous pressure is extremely low as 2 millimeters mercury. And that should make some sense to you because, as we have said a million times already, blood will always flow from high pressure to low pressure. So since veins are going to be basically the last destination for blood before it returns to the right atrium of the heart, we want it to have a very low pressure. Okay, so the pulse pressure, as I referenced on the previous slide, is basically going to refer to the pressure felt on an artery when the vessel expands following ventricular systole and delivery of the stroke volume. So if you place your fingers on either your radial artery around your wrist or your carotid artery around your neck, Every time your heart beats, you're going to feel a pulse. And literally what you're feeling with your fingers is the expansion of the arteries as it expands to accommodate that blood coming from the left ventricle. So you are literally seeing exactly when your ventricles are contracting and when they're relaxing. Calculation of the pulse pressure is extremely easy to do. All it is going to take is a measurement of the systolic and diastolic pressures and then find the difference between them. So if someone has a fairly normotensive blood pressure reading of 120/80, you would just take 120, subtract 80, and boom, you've got your pulse pressure of 40 millimeters mercury. As I said before, the pulse pressure is just going to be the increase in pressure that you feel from the delivery of the stroke volume. Now, something that is not quite as easy and is a little bit less trivial to calculate is what is called the mean arterial pressure. In other words, the average arterial pressure during the cardiac cycle. So if you don't want to deal with two different numbers and you just want one average number, this is the measurement for you. But this is not going to be a simple arithmetic average, meaning that you don't just add the systolic and diastolic pressures together and then divide by 2. We could do that if diastole and systole lasted for exactly the same amount of time, but that is not the case. As we saw in chapter 19, the ventricles spend a good amount of time in diastole and a smaller amount of time in systole. So diastole ends up lasting longer than systole does. So that's going to mean the arteries are going to spend more time at the diastolic pressure than they do at the systolic pressure. So we need to weight our calculations to account for that. So the way mean arterial pressure will be calculated is you will take the diastolic pressure and then add 1/3 of the pulse pressure. If you again take that 120/80 reading, the way you would calculate your mean arterial pressure here would be to take the 80 millimeters mercury and add 1/3 of 40 millimeters mercury, and this would give us a mean arterial pressure of about 93 millimeters mercury. Clearly, this number is closer to 80 than it is to 120, and that is reflective of the arteries spending more time at the diastolic pressure than they do the systolic pressure. Mean arterial pressure does end up being very highly significant because, as we've seen with blood flow, a difference in pressure between the arteries and the veins is extremely important to getting the blood to flow through the capillary beds. So you want your mean arterial pressure to be high enough so that it outstrips the venous pressure by enough to push blood through the capillaries, but you don't want the pressure to be too high, obviously, because then you'll end up with hypertension. We'll talk about that a little bit later. And you definitely don't want the mean arterial pressure to be too low because blood flow to the tissues will suffer and you will end up with a case of ischemia, which we talked about in the previous chapter. This chart that you see here tracks the pressure differences and the pressure changes throughout the entire circulation. So once you get into the arteries and arterioles, you can eventually see that the blood flow will always be going from high pressure to low pressure. But in the left ventricle and to a lesser extent in the arteries, the blood pressure is always changing back and forth to account for the ventricles going through their systole and diastole periods. So if you look specifically at the arteries, which is what we're focusing on here, you can see literally we toggle back and forth between a normal pressure of 120/80, 120/80, 120/80. As you get further away from the arteries, though, you can appreciate, though, that the mean arterial pressure does start to drop, and that is going to lead into the concept that we introduced early in chapter 19, which is that the pressure in the circulation will always be decreasing the further you get away from the heart and the closer you get to the end of the circulation, back to the right atrium of the heart, which is going to be the lowest pressure in the circulation. Okay, now let's talk a little bit about the theory behind how blood pressure can actually be measured. Blood pressure is measured by a device that not very few people know how to pronounce or can pronounce well. Sphygmomanometer. I may not have even pronounced it well myself, who knows. So you're probably already aware of what this pertains. The device consists of a stethoscope, which the practitioner will use to listen to the sound of blood flow through the brachial artery, the artery that is bringing blood from the shoulder through the arm. and then also an inflatable cuff, which is placed just ahead of the stethoscope. And this inflatable cuff is going to be inflated such that blood flow through the brachial artery is completely stopped. So that uncomfortable feeling you get when you're having your blood pressure measured as the cuff gets very, very tight, that starts to feel uncomfortable because that pressure on the cuff completely closes that brachial artery and halts the flow of blood into your arm and into your hand. So we need to talk about two different types of blood flow that you're going to be experiencing as your blood pressure is measured here. Before the cuff is ever inflated, so when blood flow is totally normal, you are experiencing what is called laminar blood flow. Laminar blood flow is extremely smooth, and most importantly, it is totally silent. So you could place a stethoscope up against someone's brachial artery right now, but without the inflatable cuff, you are not going to hear anything. The blood flow is far too smooth and unobstructed so that it is going to be nice and silent and you're not going to hear anything. All the different components and particles in the blood are all moving in the same direction, so nothing is kind of crashing up against the side of the blood vessel, and that leads to the silent lack of sound that you're hearing. Now, this is going to change. Once you inflate the cuff, you're going to start closing that brachial artery. So once that brachial artery really starts closing and the radius really starts decreasing, blood is going to have to kind of squirt through in order to get through it all, and that is going to cause what is called turbulent blood flow. With turbulent blood flow, as the blood squirts through the obstructed brachial artery, the different particles in the blood are all going to be moving in different directions, and this is going to lead to particles crashing up against the sides of the blood vessel, and that's going to cause the blood vessel to make very loud vibrations that will make an audible sound, provided you're listening with a stethoscope. So laminar blood flow if the brachial artery is totally unobstructed, turbulent blood flow if the brachial artery is obstructed but blood can still squirt through. So let's walk ourselves through the actual process of taking someone's blood pressure. So when you inflate the cuff to a good high pressure, something above 140 millimeters mercury, you have totally closed the brachial artery at this point. So no blood can flow through at all if you are listening right here. So this is no blood flow, so this is going to be silent. You can't hear blood flow if there is no blood flow at all. So once you have the cuff totally inflated, you are going to start opening the valve on the cuff, and you're going to slowly start releasing air out of the cuff, and the pressure on the cuff's gauge is going to start coming down. As you slowly relieve pressure in the cuff, you're going to be listening right here at the brachial artery, and once you start to just barely open the brachial artery as you release pressure in the cuff, you're going to start hearing the sounds of turbulent blood flow as blood squirts through that narrow opening and comes out on the other side and starts crashing up against the sides of the vessel. So as soon as you start hearing that sound of turbulent blood flow, stop what you're doing and look at the gauge on the cuff. Whatever that pressure reading is, that is equal to the systolic blood pressure. The reason why this is significant is because this is the higher blood pressure, and that indicates that ventricular systole is sufficient to force blood through that narrow opening so that it can come out on the other side. The lower pressure at diastole would not be sufficient, so you're not going to hear blood coming through when the ventricles are relaxed. So once you have taken note of the systolic pressure, and you are continuing to hear the sounds of turbulent blood flow every time the ventricles contract, you are going to continue reducing the pressure in the cuff, all the while continuing to hear the turbulent blood flow. Now what you are listening for is you are listening for the exact moment at which the turbulent blood flow stops being a thing and turns instead into laminar blood flow. As soon as you stop hearing turbulent blood flow, again, stop what you're doing, look at the pressure gauge. Whatever the pressure is, that is your diastolic pressure. The diastolic pressure will be equal to the blood pressure in the cuff pressure at which you stop hearing those turbulent blood flow sounds, and that would indicate that diastolic pressure is now sufficient to get blood flowing through the brachial artery. So ultimately, as long as the cuff pressure is somewhere between the systolic pressure and the diastolic pressure, you will be hearing turbulent blood flow, what we call choric cough sounds, every time the ventricles contract. If the pressure is higher than the systolic pressure, you will be hearing nothing because there is no blood flow. If the cuff pressure is lower than the diastolic pressure, you're not going to hear anything because you've got laminar blood flow. As I said, the sounds of turbulent blood flow you hear in between the systolic and diastolic pressure are called choric cough sounds. This diagram can show you the different pressures that you will see and the cuff pressure as you take yourself through this protocol of measuring someone's blood pressure. So once the cuff pressure is decreased to the point in which you hear that first choric cough sound, there's your systolic pressure. And once the cuff pressure is equal to the point where you hear the last choric cough sound, that is your diastolic pressure. All right, well, that is going to do it for this video. Thanks again for your attention. Join us next time and we will start talking about how blood pressure is regulated in the body through homeostasis using the autonomic nervous system. Should be a good one, so I hope you'll join me next time. So long, see you later.